and introduce himself.
Thank you, Linda. And let me just get my, not my emails, but my presentation up here. Let's see if I put it in presentation mode. Whoops, I think you guys see the wrong one. What screen do you see? Let me do it this way. Let me do it this way. Get out of presentation mode. Okay, I'm just gonna do it this way. It'd be easier. All right, so hopefully you guys can see my screen. And then I'll just do a quick introduction on myself. So this is Todd Rogow. I'm the CEO of Healthix. And what Healthix is we're one of the largest health information exchanges in the US. Our home base, as you can tell by my cover slide here, is New York. So New York City, Long Island, Southern New York State. And we are doing some exciting work and hope to do a lot more exciting work in this kind of area of health equality. So let me move forward in my slides. So what I'd like to cover today is, the general definition to kind of ground ourselves on where we are, understanding SDoH data, look at some of the New York City statistics, so focused a little bit on New York City, look at some of the national standards which we've been able to take advantage of. And I'm glad that Russ is going to be talking more about the standards because more work needs to be done on that front. But I'll tell you about what we're doing here at Healthix. And then I want to give you a little bit of a snapshot of what data we've already collected, which is really just a starting point for us at Healthix, and then talk about our new referral application and how we hope to leverage data like this moving forward. So let me dive right into the definition here. So this shouldn't be new to anyone on this call, but basically health equality is achieved when every person has the opportunity to attain his or her full health potential. And no one is disadvantaged from achieving this potential because of their social position or socially determined circumstances. And then we have some health equalities are also reflected in differences in the length of life, quality of life, the rates of disease, disability, and death, severity of disease, and access to treatment. So that'll just kind of ground us in our conversation today. This is probably also not new to anyone on the call today, but social determinants of health data are conditions in the environments where people are born, live, learn, play, work, worship, and the age that affect a wide range of health functioning and quality of life outcomes and risks. So I didn't throw up on the slide today, but if you look at healthcare in general, I think there's a statistic that's been broadly used that talks about 80% of someone's health is determined by non-medical parameters. So SDoH, genetics, where you live, what you eat, your housing situation, all of those things make up 80% of a person's health. The 20% that's left over is where we focus all of our energy and discussion when it comes to treating people who are in need of taking care of diseases, et cetera, and that's in our healthcare system. So it's just interesting how I think healthcare is starting to now recognize the value and trying to influence beyond, Todd Rogow breaking his leg and going into the emergency room and dealing with that, or coming down with diabetes and having to deal with that. So here's some interesting statistics on New York, in particular, New York City. And, this talks about poverty, unemployment, and the burden of rent. You look at this high percentage here, 49% in Harlem, central Harlem, struggle with paying rent. Another thing, Manhattan is also high on that list. But when you look at Harlem and overall in the city, 21% struggle with poverty. So obviously this is a problem for New York City, and the rent burden is over 51%. So these are just some high level statistics to kind of help ground us in understanding why SDoH data is so important in healthcare. And then if we look at food insecurity by borough, it's interesting. The Bronx is the leader in terms of food insecurity, so 17.5%. And again, this is a pretty recent statistic. It could have gotten worse with the pandemic unfolding, but as of December 2021, 1.4 million New York residents, so 12.9% of the whole city's population are food insecure. I think this has gotten worse. I did just hear something yesterday about this. But this again just speaks to the importance of why data around food insecurity in particular could be really important for a city like New York City. So knowing that as a backdrop and the importance of SDoH data, some of the standards that we've been very focused on have been kind of fall into these two buckets that you see on the screen. So we all know about meaningful use, and under meaningful use, they started to collect things such as smoking cessation, how much you use alcohol. The US CDI standards have also been extended to include other things over the years. So we're looking at now version 2 and beyond. And so you get sexual orientation in a broad way, SDoH data. I think there's someone who's, if you kind of go on mute if you're not speaking, or if Linda, if you could do that centrally, that would be great. So anyway, this is one of our general standards, and I'll talk about some of the data we are collecting because we do leverage this US CDI standard pretty broadly at Healthix. But one area that we've been excited about, and we've tried to work in the early years, and now this is happening, this standard called Prepare. It's not a federal standard per se, but it is a nationally recognized standard, specifically around SDoH data. And you see some private sector companies like Unite Us really focused on using this also in their work as their standard. And so we're really excited that, there does need to be some more maturity around this area for standardization, but Prepare seems to have done a really good job. And we're starting to see some of the benefit of this as well. So these are just kind of two platforms from a standards perspective that we've started to really see data come in from. So understanding where is Healthix today with current social determinants of health data. I want to give you a little bit of an understanding of data we've already been collecting. And maybe your organization has done some of this as well. So Z codes under ICD-10. And you can see some of the more dominant Z codes that we see coming in around social determinants of health data. So this is kind of the range that we've seen coming in. Again, we see some literacy, we see some schooling. There are several on school here. We see education, conviction, imprisonment, which is along the conviction. So anyway, this is, a lot of educational crime exposure. So this is kind of what we're seeing being developed as more ICD-10 codes are being deployed. When you look at how this kind of lays out within Healthix, and this is data we've already collected for 2022, you see a little bit over here around school. You see a little bit in problems related to legal circumstances. So this could be imprisonment stuff. Here's some more on education. A lot here under the other category. So there is a lot of work here to kind of tease these apart. Let me show you on the next slide, Z codes by organization. So who's sending us this information? And what I was surprised to see was I was assuming that the health systems and the hospitals themselves would be the ones who are sending us the most amount of data. But it turns out that the federally qualified health centers are really taking the lead, at least within our territory of Southern New York State, that they've been sending us the majority of these Z codes today. So they're really kind of leading the forefront, I think, on this front with social determinants of health data. And then the other one is we do pick up some from the ambulatory setting. So this is just kind of interesting to look at the spread of how the Z codes are coming in. And then the last, and then switching gears a little bit outside of the Z codes, we do pick up a lot of social determinants of health data through continuity of care documents. And as I highlighted earlier, the two meaningful use areas like alcohol use, which is up here in bold, as well as tobacco use, this is where we're getting a lot of data. And that's because there's been such a focus early on around these two kind of data categories. So we're definitely seeing strong data roll in there. But look at what also is starting to come in. So we have some education here. This is around COVID. So that's not a surprise. We have housing starting to pick up. So we're starting to pick up more data around housing situations. And then we have other things like transportation, and some safety issues. So not a lot coming in yet, but we're starting to see this all pick up. Looking at this side of the equation where we're getting the data through continuity care documents, we're kind of seeing this layout that it's a little bit different. So the FQHCs in this domain are not sending us as much data, but we are picking this up through the major hospital systems, as well as the ambulatory side. So this could be the ambulatory side of a hospital, coming through that same EHR, but this is where we're picking up not the Z codes. We saw those under FQHCs, but we're picking this up through these continuity of care documents. Again, probably entered into their EHRs that we get that data from. And here's long-term care, skilled nursing facilities. This is interesting to see that we're starting to pick some of this up through this avenue as well. So kind of a diverse set, but you can see some trends as they're evolving. All right, so that's kind of what we're capturing today at Healthix. And now what I want to show you is an application that we've started to deploy, at least within Healthix and our services, on how we can not only leverage, but how we hope as we further collect and tie into other private sector companies like a Unite Us or a Find Help, how we plan to leverage this data and talk about the referrals, because it's one thing to bring the data in, but what are you going to do with the data? What's the purpose of the data? And we want to kind of show you the referral aspect that we're starting to deploy. So let me go into some screenshots here. We have been working very closely with another HIE in New York State called HIXNY. And HIXNY kind of goes above New York City. If you go think about New York State and the state of Vermont, so it kind of takes that side of New York State, which borders the state of Vermont. So from Westchester County kind of up north and a little bit into the state as well. And they really helped deploy a couple of new modules for us. So these two here in the top right-hand corner. So typically in our clinical portal, we would have things such as visits, procedures, conditions, radiology, labs, vaccines, all of this stuff with the demographics here. But what's most interesting is up here, we bring in some social referrals. So these are referrals already made. We also bring in the history. And this is a way that our clinical users can take a few actions. So let me kind of go forward here in the slide deck. So first, we're going to take a look. We're going to click on the See All button. So this kind of opens it up. Now, obviously, this is all, fake data, so nothing is real here. But you can look at the referrals already done. So hopefully, we'll get the referral data in as an HIE. We'll be able to show that. So for Todd Rogow, we'll be able to see what referrals he's had made, and we'll see where those referrals went. And hopefully we'll be able to see that closed loop in terms of if that need has been met. But we'll also see the social determinant of health history. So in this case, it's a homelessness, and we can see where that data was collected. So this is kind of our first snapshot to understand more about the patient, to go into this detail. Now, as a clinician now, I can go in the same area. I can click on this button here and create a social referral. So let's go in and take a look at that. So there are a couple of options here. We try to make this flexible, and Hixney's done a really wonderful job on their product. The first option is we can just skip, if I don't have the time to actually make a referral to an organization that I know of who could help them, I can simply create a referral in general. And what this referral will do is it'll simply go off to an organization of care coordinators who will actually make that match. They'll say, Todd needs housing. He's reported this in this area of the city or the state, so we're going to refer him to X. And they'll try to refer me to an organization that services that area and is convenient to me as a patient. Or if you already have in mind who you want to refer them to, you can actually do a lookup. You can look up for an organization of our choice. You can find, what organization may meet the need, in this case of housing. You can see visually on a map, and then you click the refer button. So this is the easy option. You just want to simply state Todd Rogow needs some help in this area, or you can actually be more active and find that organization that can meet my needs as a patient. Part of this process is the user attestation. So again, we want to keep privacy in mind, as we're helping our patients. So this is something that we would ask our users to read through. And you can see, if you read this closely, Unite Us is in here. So in the solution that's being rolled out in the northern part of the New York State and in use right now, it does have a close connection with Unite Us in terms of all the CBOs that they work with, as well as a few other organizations. So this is something that we would read, the clinician would read to the patient, just to let them know that everything is in agreement, that they do want this referral, they do want help. They click, I agree. And then we go to which is actually way down here. And then we go to the next step here. And this is basically a little bit of a summary. And we also want to try to capture, since we've got the patient in front of us, we want to capture a few additional pieces of information. So race is one of those. And then as we go to the next page here, we also look at their ethnicity. And hopefully we can capture that. And if it's undisclosed, it's undisclosed. But this is really important from a public health standpoint. Public health in general is relying upon the healthcare structure of our local community to actually report this. They find this to be extremely useful for public health reasons, for trending and tracking and knowing where they need to apply resources. So we'll try to pick up this additional information if we can. And again, in this case, you can also talk about what the referral is for. And they need to go through screening. I don't think the clinician is going to bring them through that screening process, but that third party would. And then you can put a note here. This is an optional note. So that's kind of quick and dirty. There are two options: the easy option, or if you want to actually take and make a recommendation of where Todd should go, and then some additional information to be filled out. And then you get a thank you. You can always download this, obviously, for records if you need to on your end. Again, it doesn't have to be captured within a hospital setting only. This could be captured outside of that in a really low tech environment. As long as you have access to the Healthix portal, you can make this referral. And then the end of this is really just kind of a snapshot. This is really small print, so I'm testing everyone's eyesight here, but this is the message, which just said the referral has been made. Now this message can go to different parties, right? It certainly goes to the coordinating body in terms of who could be, doing the matchmaking, like Todd needs housing, go here. It could also go to other people such as the primary care physician, or it could go to someone else who's really monitoring their care, just to try to help with that care continuity. Just kind of bringing everything together so everyone has some knowledge about what's happening with the patient. So that is it. I do want to say that one of the wonderful things that Hixney built into this is actually an application as an app, which is available both in the Epic and Cerner stores. So the apple orchard, and I'm not sure what Cerner calls theirs, but either way, it's downloaded on the back end. So everything I showed you is kind of in context of Epic and Cerner. When you go into those work products, the EHRs, you can actually click a button, the Healthix data will show up, which was that first screen I showed you. And you can do all of that within context of looking at your patient in Epic or Cerner. And so you never have to get out of your clinical workflow. So that's really important, I think, from a time saver and convenience standpoint, that we really just try to make this as simple as possible. If for those of you who are counting the clicks, we could probably do with a few less clicks going through the phases, but just for demonstration purposes today, I wanted to show you all the different steps. But for the most part, this is tightly integrated into the EHR. And then our goal here is to tightly integrate the needs of the patient with other community organizations. So that is it, Linda.
Great. Thanks, Todd. Appreciate it. In the interest of time, I'm going to ask people if they have questions to drop those in the chat, and you can look at the chat because I want to introduce our next speaker, Nick Bonvino, CEO of Houston Health Connection. Nick, you can sort of do a brief introduction, share your slides, and tell the work group members a little bit about what you're doing down in Texas.
Thank you, Linda. Excellent presentation, Todd, and good afternoon, all. Again, my name is Nick Bonvino. I'm the CEO of Greater Houston Health Connect. We are also an HIE, a Health Information Exchange, centered out of Houston, covering state of Texas and much of the state of Louisiana. Again, similarly situated to Todd, we at Health Connect have been on this journey to coordinate clinical and social care for eight or so years, as long as I've been here, which is 9, I guess, going on 9 years. And so I'm pleased to give you an update of what we're doing. Let me, can everybody see the slides fine?
Yes, all set.
Okay, great. All right. Then okay, there we go. Okay. So just again, our mission as a health information exchange is fundamental use case, coordinate care delivery by connecting all venues of care. We're a neutral entity, not for profit, governed by a multi-stakeholder board, again, serving the communities in our service areas. We do this through a common data share agreement, our participation agreement under HIPAA. We put custom interfaces in place with our hub to all of the disparate EHRs that are being used to deliver care across all venues of care. And that deep integration allows external data to get into the clinical workflow that Todd mentioned of their EHR, which embodies the clinical workflow of caregivers. And based on that infrastructure with our base use case, we have additional value-added services, which we'll talk about as well. I just jumped ahead here. Here we go. Right. So again, just from a metric standpoint, over 3,000 venues of care. We're almost at 16 million unique patients that we're coordinating that care for, and have delivered just over the last year over 60 million documents. So again, it's over the entire continuum, not just health systems and physician practices, but all the others that you can see, including home health, rehab, and public health departments. So the base use case of health information exchange is a query retrieve model on the far left. We do the same thing with diagnostic images. For managed care applications, we'll deliver real-time alerts and use a clinical viewer to be able to see that clinical viewer underlying what is happening with that patient. We have a whole host of services under health services research, and specifically projects oriented around the topics of the day, including tracking what we believe to be, or are told, the largest cohort of positive tested COVID patients in the world. And then under the category of public health, which includes the typical syndromic surveillance through electronic reporting of labs and the such, is our Social Determinants of Health exchange and the closed loop referrals that we're doing to community-based organizations. So similar to what Todd had mentioned, there's lots of data out here that describes, that perhaps up to 80% of the care utilization cost is driven by non-clinical factors, so non-clinical determinants of care, in other words, and that HIEs are really uniquely positioned to be able to address this issue. And this is just a next slide here, just showing where those other factors are in addition to the 20% of actual clinical care that's being delivered to get to a place where we're treating the whole person. So the fact that we're addressing social determinant data at the point of care can better inform decisions, first in the initial assessment and diagnosis, and certainly treatment plan, but it empowers providers and engaging the provider community to assist in areas they don't provide social services, but addressing that with the large number of providers that exist will definitely have an impact of improving the clinical care, the outcomes of that clinical care for many of those that are carrying risk, managing that risk, and certainly addressing health equity. An HIE integrating a closed loop referral tool, much like what Todd was showing you, starts with data. What we've found in our experience over the years is that clinicians don't want to ask, patients don't want to tell. This is highly sensitive information. But to have some of that available, even a risk factor at the point of care, can help start that conversation, which could lead to identifying what those social needs are, and the tool being able to deliver a referral to entities that can address that underlying condition. We're addressing this on a community-wide basis. So kind of a byproduct of a system like this in place across communities is to really get a chance, and we have that analytics engine sitting on the top of our transaction stack that can really get a pulse on the needs of a community when it comes to non-clinical determinants and what those issues are, the referrals that will be taking place, how well they're being met and addressed. So that's the overall strategy and why engaging the provider community through HIEs makes an awful lot of sense. So the referral tool that we're using is just a little bit of a different approach that what Todd just described. We are actually going to be connecting, in addition to those thousands of provider organizations, connecting to our HIE social service agencies. So the heart of this system is being able to connect those social service agencies dealing with those underlying non-clinical determinants so that the referral can be made. So step one in the strategy, much like what Todd was talking about, we were able to document access the codes that are being used today in the healthcare delivery organizations. And, and just as Todd had showed, I think it was several 500,000-600,000, we have a similar number as well. And that's just, again, dealing with the clinical data that's coming through us, all the different codified conditions that exist. And in this case now, the Z codes that were created to document social determinants of health. We took another step further because that, while several 100,000 is a good step in the right direction, against 16 million unique patients, there was an opportunity to populate an additional or to access additional source of social determinant data. So we've gone out to the marketplace and acquired that and configured it such as an additional data source just like it's, lab results coming from a lab, hospital visits from the like, freestanding, all the different sources of a patient's information. From a clinical standpoint, we're adding social determinant data so that when this information is delivered to the point of care through the normal HIE care coordination process, this social determinant data will be included in that, and again, to better inform decisions at the point of care. Sorry, let me back up one. This is a typical process set in a primary care setting where a social determinant is discovered through the visit process, and how through the needs assessment that would follow, creating of the referral, that referral ended being directed to a social service agency, that social service agency either accepting, rejecting the referral. If the patient actually shows up, documenting of that back to the source of the referral, and anything that was performed as well, resulting in a closed loop referral process, one that is originated by the provider communities that uncover this need, having that match to a community-wide resource directory of social services agencies based on their location and based on the service that they provide to address those non-clinical determinants. And then sending of that referral, and then the closing of the loop with social service agencies delivering it back. So very busy slide, but I think you get the idea of the workflow, leveraging HIE assets to deliver closed loop referrals across the community. So this is what we're rolling out as we speak. On the left-hand side are some of the largest health systems, the largest FQHC in the state, Legacy, and another clinic that addresses the needs of the underserved specifically. In the center is our hub. At the very bottom is the GHH hub that I described, that has been in place for almost a decade or so, and doing that clinical exchange to deliver information to the point of care. What we're putting on top of that is our social determinant platform that imports social determinant data to combine with that clinical data, and then a module of referrals that, again, empowers and engages clinicians to actually deal with those underlying social issues in addition to the clinical needs that they do every day. On the right-hand side are the social service agencies that we have rolling out. Combined Arms is actually what's called a CIE, a Community Information Exchange, which is a collection of these community-based organizations. The rest are who you would expect: the United Way, the Food Bank, other organizations, and government that tend to these social services needs. And again, it would go initiated on the left by providers through our hub, matched based on need, based on proximity to the patient, landing at an agency that can deal with that underlying issue and closing the loop, resulting in a unified care record of both clinical and social data that can absolutely impact the outcomes that we see in our healthcare delivery system today. So those are my remarks. I'm going to stop sharing unless somebody has a specific question on my slides. I'll hold it for a second.
Thanks so much, Nick. Any questions for either Nick or Todd? I saw there was one in the chat that Todd answered, but any questions? I think that you're both doing phenomenal work, and I know that you're early stages, but I'm going to ask both of you, do you have a way or a mechanism or plan to measure impact? How are you going to do that as you start to roll this out?
Sure. As I mentioned, the analytics engine that will actually be able to take all of the transactions that are occurring, referrals that are being generated, those that are accepted as well as rejected, what agencies are participating which providers are participating, and then the closing of that loop is what actual social determinant services are being delivered, and for a community-wide approach, which again differs a bit. There's companies that are out there that are connecting to health systems. Todd mentioned Unite Us, Find Help are two of those, and they are really centric to an organization versus a community. And so that's why we believe this is an approach that'll be a common tool across all provider organizations, connecting just one time to all those community-based organizations so they don't have to connect to different vendors. And then analytics for the entire service area, that community that we're serving.
Thanks, Nick.
So Linda, I would just add really quickly that some of the KPIs that we're really tracking, because we're very mission driven and we want to see the outcomes change for these patients. So what's nice about an HIE is we have all this clinical information about the patient already. So this referral and SDoH data just supplements that. So we would look to, as Nick pointed out, making sure that that referral is made and that is followed up on by the patient, right? It's a closed loop referral. But what we also want to do is then look at that individual's health over time. And we hope to see that trend obviously in a positive direction. That's assuming they had the referral, that their needs were met, and hopefully they're getting better now. So that's just the value add from an HIE perspective. I think we can add to just simply a referral system standalone. We have that historical information about the patient already, and we do want to see those trends move in the right direction.
Great, thank you again. I think your organizations are doing phenomenal work, and it's great to see the addition of SDoH and the referrals systems being put in place at a broad community, even statewide basis. So at this point, and again, if people think of questions, please drop them in the chat. I'm going to turn it over to my colleague Russ Leftwich, and the reason I invited Russ is because one of the things this Workgroup should be doing is thinking about how can we add value to the larger sort of health IT ecosystem. And I think Todd mentioned that they're bringing in SDoH data. They're looking at different Z codes and terminologies that they get through the CDAs or the CCDAs. But generally speaking, there is not a good one place to go when you're trying to look for nomenclature structures. There's census data. There's all kinds of data depending on what you're trying to look at. HUD puts out data on housing, and there's data on food insecurity nationally. But again, bringing that all together is really difficult, especially at the patient level. So Russ, I'm going to turn it over to you. You can introduce yourself and then charge forward. Russ, you're on mute.
Yes, thank you. I knew I was on mute and was struggling to find the unmute button. Thank you. I'm Russ Leftwich. I am a senior clinical advisor to InterSystems around interoperability. My intent is to sort of do a high-level overview and not a lot of details. I think it's appropriate and it's fantastic that the implementation is ahead of the development of the much needed standards to support the social determinants of health use in improving care. I will start out by asking you to indulge a historical glimpse. I know the images I see on the call, you're young folks like Todd and Nick. I started practice in the 80s in Nashville, Tennessee, and the first half of my practice was on paper. One of my first responses to social determinants discussions was, this is not new. Some people seem to think it's a new discovery. We knew about social determinants. They just weren't captured as such. It was the type of thing you wrote on the paper jacket of a patient's chart, that they didn't have a phone, and their neighbor's phone number was ... And we dealt with that. Hospitals, if you're not haven't been part of a hospital environment, had social workers on staff, hospitals of any size. And that was the mechanism, if you will, of dealing with the social determinants of health. Fast forward to 10 years ago, when I was the CMIO for the state of Tennessee's Office of eHealth, and one of the gaps that we dealt with was that the various social service agencies of the state of Tennessee had everything on paper. They weren't connected, but it didn't really matter because everything was on paper. And so this is a much needed advance. Some of the social determinants of history are, of course, part of the social history part of a patient's record, particularly those around substance use and such. But the other social determinants really weren't often available in the patient's record. And still, a lot of it doesn't exist as electronic data. And when it does, it's not connected. So there are various categorizations of social determinant of health domains. I've listed the ones that have been the focus of efforts in HL7 around developing standards for social determinants, the food insecurity, housing insecurity, financial insecurity, transportation issues, and health literacy in particular. Those are often broken down into subdomains, which I won't try to detail today. But there is not, to my awareness, an agreed upon way to describe all of the social determinants domains and label them exactly. So what I wanted to talk most about was the Gravity Project. It is one of the FIRE accelerators in HL7. It is one of the first 3, and there are now some 10 or 11 such projects. They are, if you're not aware, externally funded and externally driven projects in HL7, managed by HL7 to accelerate the development of FIRE artifacts in a particular domain. The Gravity Project was really initiated by a group at UCSF in San Francisco that had a pre-existing project called Siren around social determinants of health. And the initial effort was to develop terminologies and a structured data schema for social determinants of health. That was what was initially brought to HL7. I should say I haven't been a hands-on participant in the Gravity project, but their initial goals were to develop use cases for development of recommendations about documenting social determinants of health data in EHRs in particular. So not really addressing the other systems that contain social determinants data, and to develop the data sets that were needed to support the social determinants use cases, and then develop recommendations on how to capture the data elements and make them interoperable, particularly as using FHIR as the interoperability format. So that Gravity project was initiated in 2019. The second phase, beginning in 2020, was about collaborating with terminology organizations to close the terminology gaps that existed around social determinants, particularly to support the development of FHIR implementation guides for social determinants. In November of last year, Gravity published version 2 of a social determinants of health clinical care FHIR implementation guide. I won't go to the details of that guide through this link, but it's important to point out that FHIR implementation guides are part of developing the standard. They are not, as the name might imply, ready to go out and use in practice. They're more for testing and piloting, and not something that's ready for prime time use, if you will. So version 2 is a update of that implementation guide based on use of version 1, but it is by no means complete and ready to implement. So part of the Gravity effort has been to identify and develop where needed terminologies and code systems. Todd showed you a more specific part of the Z codes from ICD-10 around social determinants. This is a list, a broader list of some of the codes that include health literacy, physical violence in an individual's life that becomes a social determinant, financial and food and housing issues all have Z codes. There are some additional Z codes that exist. If I were designing a domain model for social determinants, I wouldn't start with ICD-10 codes. Nevertheless, I understand why that is where we've started, because we can make use of that early on and implement the types of applications that Todd and Nick have described. The other area where there's been a lot of work in the Gravity project, but still very much in its early stages, is with LOINC codes. There is a so-called LOINC code group around social determinants of health. It is in beta still, so these aren't ready to publish and use broadly either. But this is a sample listing of the subgroups of these LOINC codes. around economics, education, food, and so forth that exist. And if you're not aware, for LOINC codes, there are so-called LOINC panels that are both the observation that can be made as a question, if you will, and the potential answers to that question, because part of interoperability that may not be immediately apparent is that you not only have to standardize the values of things, but you have to standardize the question you ask and the potential responses if you're really going to have interoperability across systems and domains. So I see the time is getting late, and I will stop soon enough for any questions you might have, and we'd be glad to come back sometime and address some specific areas that you could identify as of interest.
Yeah, so I think, Russ, thank you. I appreciate it. One of the questions I have real quick is, what work still needs to be done? And is there a role that we could play to help with some of this in terms of making a broader audience aware of the different types of ontologies that are available? Also, what do you do when you're trying to map from a CDA that doesn't have a LOINC code associated with something, or you're trying to use the census data, or you're trying to use, again, other data sets that are out there that may not be, quote, healthcare related, that we want to take advantage of?
Yeah, I mean, all of that is just defining the definitions of terms is still very much incomplete, but also identifying the value sets in the systems that they are used in. Like you say, like you mentioned, that there's a lot of data out there that is not in any traditional healthcare data system, electronic system, that needs to be defined and data sets created. I think there could be some very valuable feedback from the social services referrals that are being developed and actually utilized around what value sets, what concepts are missing, and would be helpful to pass back to the Gravity Project and others who are working on this, and at the same time testing some of the value sets that are being developed and some of the terminologies like the LOINC panels around social determinants of health. I think it would be very valuable to implement on a pilot basis some of those and give feedback to the organizations that are developing them for certain, and then to test the FHIR implementation guides that are being published. As I say, they're not ready for
Prime time,
but they are in a state that can be implemented and piloted.
Great. Well,
So,
I know we're at the top of the hour, so I want to thank you and Todd and Nick for joining us today. This has also been recorded, so members who couldn't attend will be able to listen, but great information by all of you. So thanks again for joining. And we're not meeting next month because it's our spring conference, but we will be back again in June. So take care, everyone. Thank you.
Thank you.
thanks.